Good afternoon to respected chairperson as well as Dr. Nagarjuna and Yashoda Hospital for inviting me to speak on EBUS. Now, I have been assigned a talk on EBUS for mediastinal cyst and pulmonary vascular pathology. So, throughout the 2 days discussion, you must be aware of the fact that predominantly EBUS is done to diagnose the disease and second for the lung cancer staging. So, these are some uncommon indications of doing the EBUS. Now, I will cover my talk initially on the pulmonary vascular pathology and second part I will focus on the mediastinal cyst. To know about the pulmonary vascular pathology, as I already told you, you need to be aware of the fact that what are the windows through which we will see the pulmonary vasculature. So, predominantly I will not go into the details of the anatomy because it has been discussed already across the 2 days. So, predominantly as we all know, the station 4L, station 10R, station 10L, these are the windows through which we will see the pulmonary artery. And when we will talk about the pulmonary vasculature, one is the main pulmonary vasculature and one is the segmental and subsegmental. So, it is predominantly for the main pulmonary vasculature to diagnose the pulmonary diseases. So, as we go, so what are the pathologies which can be detected by EBUS? Number 1 is a thrombus in the pulmonary artery, tumors arising from the artery. Third is the external tumor infiltrating into the pulmonary artery, and fourth is the vascular aneurysm. So, to make things simple, I will go by certain cases. There is a disclosure, 2-3 cases I have taken from the internet and 4-5 cases is from my experience across 2-3 years. So, the first case to start with, this is a 62-year-old male who is a follow-up patient and now presented with a lymphocytic exudative low ADA pericardial effusion. You have done the PET CT scan and on PET CT scan the mediastinal and hilar lymphadenopathy. So, apart from that it is a very simple case. So, you are suspecting a malignant pathology or a tubercular pathology because of the lymphocytic exudative pericardial effusion and you have planned to do an OP EBUS. So, on OP EBUS, while your main focus is to make the diagnosis, you have found a certain floating echogenic structure within the left pulmonary artery. So, the question may arise, what was there in the PET CT? This should have been picked by the PET CT. So, there may be some cases that at that time the PET CT there was no pulmonary thromboembolism. However, while doing EBUS, it was found to have a segmental pulmonary embolism and that is why it was repeated the CT pulmonary angiography to confirm the diagnosis and it was found to have a pulmonary embolism. So, there may be PET CT or CT scan in which it may not be there, which may be incidentally picked up by the EBUS. Going to the case 2 is completely different scenario. A 47-year-old male returned from the vacation had a sudden onset of shortness of breath, had a cardiac arrest followed by return of spontaneous circulation and echocardiography showing right ventricular strain with an raised pulmonary artery pressure. You can well assume this is a classical setting of the pulmonary thromboembolism. However, the patient of pulmonary thromboembolism when is in shock, you cannot transport that patient a lot of the times for diagnosis or for CTPA purpose. So, you can empirically thrombolize the patient based on the echocardiography finding, or is there anything to support you medico-legally as well as for the patient benefit. So, in this case also the echo or the bedside EBUS may be helpful to clinch the diagnosis. So, these are the cases of endobronchial ultrasound beyond the nodes and the masses, and we can see there are number of papers who have discussed this between the time period of 2013 to 2018-19, this time period. So, now the EBUS for detecting the central pulmonary emboli, this is a pilot study where they have found that it is the CT pulmonary angiography and EBUS, they correlated more or less, and 96% of those emboli which was diagnosed by CT pulmonary angiography can be picked up by the EBUS. So, it can act as a replacement tool for the CT pulmonary angiography. And if we go this pilot study to evaluate the role of the EBUS in the diagnosis of acute pulmonary embolism in critically ill patient, we can conclude from this study that it can be act as a substitute because of the shock the patient may be having acute kidney injury as well as no urine output. So, we may avoid the contrast induced nephropathy as well as the risk associated with transporting the patient where it is not feasible to do the CT pulmonary angiography. And in this study, we can see the exclusion criteria more or less are same as that of doing bronchoscopy. That is practically, unless the tube size is less than 8, you can do EBUS in all those critically ill patients. So, those patient who is fit for bronchoscopy probably is also fit for the EBUS. More in the COVID era because of the rapid evolution of the post-COVID fibrosis and those kind of thing where the patient is on mechanical ventilation for a long period of time and the patient is on ECMO. Now, you cannot use empirical anticoagulation because of the fear of the ECMO. You all know lot of anticoagulation is already going on. On the other hand, post-COVID, as we all know, is associated with a significant pulmonary thromboembolism. So, you cannot do CTP of those patients. Probably on that context, EBUS is the only alternative method. And you can see again in this study the agreement between the EBUS and the CT pulmonary angiography is, apart from 2 cases, almost the findings were similar to each other. So, 2 different cases which I showed you with different intent, one incidental diagnosis just while doing a different procedure, and second one which was done with a diagnostic intent. So, now whether it has got any role in the pulmonary embolism therapeutic. By therapeutics I am meaning post thrombolysis. So, post thrombolysis, whether your thrombolysis has worked or not, whether we can monitor this kind of things also with EBUS. This is a study which was done with the pigs where they have found the dose of the as we all know, the thrombolysis can also be done by catheter directed thrombolysis. Here they have done EBUS directed thrombolysis directly into the pulmonary artery, and they have found the dose of alteplase which was required was almost 1/3 of the alteplase which was required for the systemic thrombolysis. So, the dose of the thrombolytics can also be reduced. Now, if you ask about the pulmonary artery tumor, first it is not as common. So, the diagnosis to have a suspicion of pulmonary artery tumor, it is also very difficult. So, the mediastinal vascular tumors are most of the times diagnosed as pulmonary thromboembolism. In fact, failure with the anticoagulation sometimes give an idea that probably we are dealing with a neoplastic pathology contrary to the finding of pulmonary thromboembolism. And if we can see, these are the tumor which will mimics like pulmonary embolism, very difficult to diagnose. So, the pulmonary artery sarcoma diagnosed by the transbronchial EBUS TBNA, and the patient was subsequently referred for the surgical intent. These are the finding where through EBUS the diagnosis can only be achieved. And successful EBUS guided TBNA aspiration of tumor thrombus, again I already showed you. This is a 66-year-old male smoker. A left upper lobe mass was noted with a direct tumor extension into the left pulmonary artery, where you can see clearly. So, in this case also with the EBUS TBNA you can achieve the diagnosis, and also use of EBUS TBNA in the diagnosis of a very rare condition of pulmonary artery aneurysm, where the lesion will be smooth, fleshy and looked hypervascular, pulsatile, and EBUS was done. And this was the finding of the EBUS. The findings reciprocated the same finding that pulsatile biopsy was abandoned and the EBUS was done, and the left pulmonary artery aneurysm diagnosis was made. So, this is the fact which I want to tell you, that you need to be aware of what you are exactly dealing with. Another thing is regarding the mediastinal cyst. So, mediastinal cyst, there may be multiple pathologies, there may be an anterior, posterior. So, whether does it require sampling? This is the big question. Why do we require sampling? Because if it does not cause any kind of pressure symptom, it will not cause anything. So, is there any point of diagnosing? Second thing is that if it is causing that kind of compression symptom, should we proceed directly for the surgery, or should we confirm the diagnosis initially by the EBUS followed by the surgical procedure. So, this is a patient of a 65-year-old female presented with a complaint of non-specific heaviness in the retrosternal region, and cardiac evaluation revealed no significant issue, and this is the chest X-ray. While CT scan was done, we can clearly see there is a cystic round non-enhancing lesion in the right paratracheal region with a probable suspicion of bronchogenic cyst which is compressing on the trachea. So, we did the EBUS guided aspiration, and we can see this is the material which has come out, around 60 ml was drained out. The repeat picture was not there with me, but around there is a significant reduction in the size of the cyst. And the culture was negative, AFB staining was negative, and FNAC, as we all know, paucicellular smear, few mature lymphocyte and benign cystic lesion was diagnosed. So, when we diagnose a bronchogenic cyst, how to diagnose a bronchogenic, what are the confirmatory point? Yielding a significant volume of non-bloody material, a greater than 0.5 ml. Second, presence of bronchial epithelial cell, which is very important. If you find mesothelial cell, it will go more in favor of pleuropericardial cyst. Number 3, absence of the malignant or necrotic cells, and 4 is the aspiration undertaken in a sitting where the clinico-radiologically also you are suspecting bronchogenic cyst. So, for the confirmation of the diagnosis, excision is the method of the choice, and you still require histopathology of the cyst wall for the confirmation. And so, is there any point, again I will come to that point, is there any requirement to make that diagnosis, because we may go straight away to the surgical, and we are not suspecting any malignancy clinico-radiologically. Advantages, main advantage, it rules out the neoplastic one. Therapeutic aspiration shrinks the size in those patients who are not fit for the surgery, and it will also document the cyst infection and drainage in cases of abscess and some improvement in the pressure symptoms. But we should be aware of the cyst rupture and the cyst infection. Now, this is an article also regarding the role and safety of the EBUS guided TBNA in the diagnosis as well as management of the infected bronchogenic mediastinal cyst, and they found that in most of the cases the culture, although grew in a very small number of patients, the important message is that in most of the patient the diagnosis was not made. Only on 27% of the individual the diagnosis was made, and the rest of the 73% the diagnosis was not made. Number 1. Number 2, in those kind of patient, among those 27%, the therapeutic intent was achieved only in 10% of the population. So, there is no requirement of blindly puncturing all the mediastinal cysts just for the sake of the doing it. Now, cystic lesions with extrathoracic manifestation, one is the hydatid cyst, second is the lymphoma rarely, third is the bronchogenic cyst with no extrathoracic issues. Hydatid cyst rarely involves that mediastinum 1 and probably is the cyst which we should not target via EBUS TBNA. So, should I sample them by EBUS TBNA? As I already told, this is a case of pulmonary artery hydatid cyst which was observed on the EBUS TBNA, and where we can clearly see. So, this is another patient, 57-year-old lady from Mizoram. He was a follow-up patient of CA esophagus. He came for the follow-up of gastric pull-up surgery. She complained of some-sided right-sided chest discomfort, and PET CT was done, where we can see there is a high uptake area, and this is, to be more precise, this is the area. Then we opted for the EBUS guided TBNA, and we can see there was a fluid purulent material which was coming out through that. So, this was probably an abscess, and on culture we found out to be Pseudomonas aeruginosa. So, this is a case of probably post-operative infected collection. So, now for audiences I will just ask two questions. Number 1, this is the first case, a 43-year-old asymptomatic male who is working up for a visa purpose. On routine evaluation got this chest X-ray, and this is the CT scan. So, what should we do? we will leave it just like this. We will counsel the patient, and as well as we all know, for the visa purpose you need to give the fitness. Second, I will go for the PET CT scan. Third, I will go for an EBUS guided TBNA, and fourth, I will straight away refer to the CTBS surgeon. So, your polls please. Next slide. So, I am moving to next question. I will come to this later on. So, this is the question 2. A 47-year-old male who is a patient of glioblastoma multiforme, who was referred with a sudden onset hypoxia with more or less clear chest X-ray with a saturation of 70, just last week's case, with a creatinine of 1.9, and he was requiring around 8 liter of oxygen. So, a 47-year-old male post radiotherapy patient, acute onset hypoxia requiring 8 liter of oxygen. So, this is the chest X-ray. Now, what should be the approach? The patient is also having a shock, which I not mentioned here. So, whether we will still go for CT pulmonary angiography, whether we will thrombolize the patient. Number 3, whether we will give empirically therapeutic dose of low molecular weight heparin, or fourth, we will go intubate the patient and then we will do the EBUS. So, your answer please. So, just to cut short the take home point from my talk, yes, EBUS can be used to diagnose pulmonary embolisms, especially in those patients who are on ECMO, or in those patients it is difficult to perform CT pulmonary angiography. In a typical ARDS patient where the patient is requiring a significant oxygen and you cannot have that facility of doing portable CT, you can have the advantage of doing the EBUS to diagnose whether they are having any main pulmonary artery embolism or not. Ultrasound understanding of pulmonary vasculature is most important. ET tube size of 8 or more is required. Aspirating fluid will not give a diagnostic answer. Mediastinal cyst can be approached by EBUS, but need to be sure why I want to do it. Hydatid cyst TBNA is debatable. Aspirating a bronchogenic cyst can give some sort of temporary relief. So, it should not be blindly done for all kind of mediastinal cysts. Thank you very much.